Thank you very much. I really appreciate this opportunity to come here and present at this meeting. So I want to talk on what India is doing to bridge the gap between in providing equitable cancer care to all its people. So we have a population of 1.4 billion plus, and we see over 1.4 million new cases every year, and more than half of them will die of their cancer. Common cancers are oral, lung, stomach cancer. This changes by the region. India is like a continent, and different areas have different cancers which are much more prevalent. Women, breast, cervix. Breast cancer is more than cervical cancer now, and ovarian cancer, which is slowly increasing. Some parts of India show gallbladder cancer to be a very common cancer in women, and in fact is the #2 cancer. Now there are reasons why many of our patients die. They're not very difficult to see. There is late diagnosis, and then there is a lot of treatment deferral. And there are socioeconomic disparities, there are geographic disparities. Where I work in the Northeast, transport and travel is a very big problem. And then there are social and cultural barriers. There is a very strong faith in much of the rural community in native indigenous healers. And many of them will prefer going to native healers than go to a hospital. Now, over the last many decades, we have done many things in the country. But to me, as of today, the three most exciting things that are happening in India are one which is happening in the government sector, the Ayushman Bharat program, one which is happening because of collaboration between professionals, cancer care professionals, which is the National Cancer Grid, and then what is happening in the non-governmental sector. So I want to just talk on these three. So Ayushman Bharat is a flagship program started by the government of India about 7-8 years ago. And today, more than 60 million people have been brought under the umbrella of the Ayushman Bharat. This is basically a scheme wherein every family is provided rupees 5 lakhs, which is how much? How many crores? I'm not sure. Okay, 50 lakhs is 50 followed by 5 zeros. So much of money. And then slowly it has been expanding. Initially, they started with people who were below the poverty line, and then the bracket increased to people who are around the poverty line, and gradually the idea is to bring about 90% of the population within this umbrella. And over the last, since it was started, 6.8 million therapies have been given, not 6.8 million individual people. But the important thing is, nearly 40% of the population initiated treatment within 30 days of diagnosis. And more than 90% of these people fell under the PMJY bracket. Yes, there is financial protection, but there are large loopholes. And then there is infrastructure and technological innovation, which is happening within the milieu of the Ayushman Bharat. I will come to that in a little minute. Just to give you an idea, in our own hospital, I work for a not-for-profit rural cancer center in the Northeast. And there, before Ayushman Bharat started, about half our population was not able to complete cancer care. And since the inception of Ayushman Bharat, now nearly 80% of the patients who report to the hospital are able to complete cancer care. There will be other confounding interventions, but Ayushman Bharat, to a very large extent, has contributed to this. So what are the policy implications for equitable care? So there we have to deepen the coverage. We have to bring more of the population within the coverage. The urban poor are left out. There are populations which are migrants, which don't have access to. We need what are called Aadhaar card. We need what are called income certificates. These certificates are not available, and these are the people who actually need the care the most. And these people are often left out of the bracket. So this is something that we have to address. We have to address social gaps. And rural and tribal population often are not able to go to a hospital in order to go to the government in order to get accommodated under the program. What has now happened is individual hospitals have been empowered to include patients into the Ayushman card, Ayushman Bharat scheme, provided they have some basic certification necessary. And then we have to ensure financial risk protection. We have to learn to bridge the difference in care provided by public sector hospitals and private sector hospitals. This will take time, but this will eventually happen. Digital health and data-driven governance, in a minute I will come to it. And then we have a very large set of alternate stream medical practitioners that we term as Ayush, who practice Ayurveda, who practice homeopathy, who practice Unani, who provide very valuable care in the community. And they are often, ignored by people like me, allopathic stream practitioners, but they actually provide a lot of invaluable care to the community. And we need to bring them within the fold of cancer care so they can also become part of the system. We must learn to integrate them within the system. This is just an infographic about how the NDHM, National Digital Health Mission, works. It used to be called NDHM. Today it is called Ayushman Bharat ABDM. AB something. Anyway, doesn't matter. The thing is, everybody has been provided an Aadhaar number, has been provided an Aabha number, which is a unique health identity number for every citizen. And that will be linked to all the systems that operate in the healthcare milieu. And so a patient going to some hospital in Mumbai, then subsequently going to Lucknow, then coming to Kolkata, we will be able to track them across the system and have instant access to what is happening. And this, I think, will be a real game changer in the way we manage cancer patients. The next thing that I want to talk about is the National Cancer Grid of India. So this started in 2012 with a small group of institutions. The idea is to bring a whole lot of cancer centers, patient support groups, research groups, non-governmental organizations, all engaged in cancer care into one network that we call the National Cancer Grid. And today we have more than 360 member institutions, and more than 60% of all cancers treated in the country are treated in one of the NCG institutions. And the idea of forming this was to have uniform standards of care across the country, to develop trained human resources across all the centers that are member institutions, to participate in collaborative multi-center cancer research. And last year we added framing that we want to be part of the national policy development that happens in the country. These slides, I borrowed from Pramesh, my colleague, who is the convener of the National Cancer Grid. So we do many things. I just chose 4 instances for each of these. In order to develop uniform standards of care, we sat and wrote down guidelines for cancer care that will be applicable across the country. See, we have very poor patients, we have very poor institutions where the latest targeted therapy may not be applicable and may not give the kind of benefit that it should be giving. And so we have actually, as part of the NCG, we have a health technology assessment panel. And so we will tell them, so these guidelines are resource stratified. What is basic minimum cannot be compromised. What is ideal and what is, the dream that we can follow. The other thing is we have accreditation policies across the country. We have JCVI and we have NABH and all of that. And but they are all paperwork driven. And so we started doing institutional peer reviews. We have members who participate in the peer review from different cancer centers, who visit different cancer centers by invitation, and they assess the standards of care in the institution and provide support in order to change. Incidentally, we were the first center to be peer reviewed in the country. And then we have standardization of surgical pathology across. So initially we were taking physical slides from different institutions to a central institution, the Tata Memorial Hospital, for assessing the quality of the slides, for assessing the quality of reporting. Now all of this has become on a digital format. And then the most exciting thing that actually has instant benefits is group negotiation for drugs. Cancer drugs cost a lot of money. Cancer equipment costs a lot of money. When I joined the hospital in 2007, I wanted to buy contrast from a company, and the company agent would not even come and meet me. 2 years later, our volumes grew, and so he asked for a meeting with me. And then what has happened as part of the National Cancer Grid is, as one institution, if I negotiate, I will get some reduction. If we negotiate as 300 institutions, we get a lot of reduction in cost, and many of the drugs we are able to achieve almost an 80% reduction in the cost when compared to the MRP. And to me, this is one of the most significant things that will help bring about uniformity and quality of care across different institutions. In order to train human resources, we have a national library, we have a discovery tool called Akshara, through which we do this. We don't have good quality pathology work in many institutions. So we devised what we call a traveling school of pathology. We have a group of pathologists and pathology technologists who do the sectioning, staining, and they go from center to center to center to center, teaching different institutions how to standardize grossing, how to put out good quality slides, and how to use synoptic reporting. For research, we have the Credo workshops, which are one of the 4 across the globe. And now we get applications from different countries in order for people to participate in research methodology programs. And then we have online training tools in the National Cancer Grid website in order to have online training. For research, we have a central research secretariat. And then, as I told you, we have these Credo workshops. And then we focus on supporting research projects where essentially we must have multi-center collaborative research. It must be for common cancers in the country or for unique cancers which are rare. They have to focus on cost-effective treatment. We will only support research if the data is made open source. Otherwise, we will not support research as part of the National Cancer Grid grant. And then we have now a Center for Digital Oncology. And then we have now identified key research priorities for LMIC. So we said it must reduce the burden of cancer patients presenting with advanced disease. We said it must improve access and affordability and equitability. It must be health technology driven. It must result in quality improvement, and most importantly, it must leverage all available technology in order to make cancer care equitable and affordable. In order to become part of the policy making of the country, so we already work with the Ayushman Bharat scheme. We participate in their meetings in order to decide what should be supported and what should not be supported. We then inked a thing with the NABH, that is the accrediting agency, in order to see how accreditation for cancer centers could be done. We are part of the National Digital Health Mission in order to have standard online EMRs and data that can be easily made available to the government and to different agencies. And now we are encouraging other nations in this South Asia, Southeast Asian region to develop their own cancer grids, and we are happy to support them for that. Now, both the Ayushman Bharat and the NCG work very closely with each other. The third thing that is happening across, we are a democracy, and so all non-governmental organizations have a very big role to play in the development of equitable cancer care. And non-governmental organizations, because they have an easier governance system, they are not as unwieldy as the government, they are more nimble, and they can change things and implement strategy very quickly and show outcomes. So they contribute to awareness, they contribute to a whole lot of activities. And there are several centers, several institutions across the country that provide financial support, that provide navigation support, that provide emotional support, several things that happen. And they work, non-government organizations often focus on low resource areas in the country. They serve marginalized groups. They fill in gaps wherever there is lack in awareness or early detection, for financial support, for social support. They provide culturally competent care, and they reduce out-of-pocket expenses. But then, like all non-government organizations, they have challenges. They don't have enough resources, they don't have money, they don't have people. So if all of us sort of collaborate together we can bring about change in the country. Ours is a non-government organization. We are located, just to give you an idea, on the eastern side of Bangladesh. Bangladesh comes up in the eastern part of the country, and there's a large area of the country which is to the east of Bangladesh, linked to the mainland by what is called the Chicken's Neck. And we work in the southern districts of the state of Assam, and like other parts of the country, we have our own sets of problems. We have problems of transport. Often sick patients are carried on makeshift hammocks. We have areas, where access is very difficult. There are single-line bamboo bridges. There are areas where they're filled with, routine problems. And as an institution, at one point of time, we were treating less than 30% of patients coming to the hospital. And so we put in place without actually understanding what we were doing, but we put in place pro-poor policies and actively branded ourselves as pro-poor all the time. Everywhere, the way we talk, the way we look, the way the hospital appears must reflect our pro-poor strategies. Then we resorted to cost reduction strategies, lowered the cost of care, lowered hidden costs, lowered costs, eliminated costs for repeated outpatient consultations and tests. And then we resorted to reducing waiting lists because many of our patients are daily wage earners. Every day they lose in the hospital is day's wages lost, food is difficult at home. And so we put in place a lot of strategies to reduce the waiting time. We task shifted. Where a doctor is not available, a technologist can do the biopsy. Where conventional paraffin section takes several days, we resorted to frozen sections. So the day the patient comes, the next day morning he has a biopsy, he has the pathology report, he has the imaging done, and the treatment plan. So our target is within 24 hours, we must be ready with the treatment plan. And so this happens and then we use technology very aggressively. We don't have an intensive care unit, for example. We don't have intensivists in the hospital in the whole region. And so we teamed with a group of intensivists in Bangalore who work on the cloud. In many countries, this may be a more standard of care, but for us, it's a very big thing to be able to practice cloud technology to deliver, and it saves lives. And then, but our biggest strength lies in our engagement with the community. I'm running out of time. Okay. So we did several things in order to improve our engagement with the community. We started working with community activists in order to do screening in the community. We switched, I worked very well. We switched to, I would be very happy to talk to anybody because I'm very, very passionate about this. So we can talk later. And then we switched over to getting the same activists to deliver healthcare messages in the community to promote early referrals. And then we started working with different government agencies to deliver the same set of multi-sectoral convergent messaging to improve access to care. And then we started asking questions. We are doing all of this in a project basis. How do we sustain it once we run out of the project? And so we looked at livelihoods, we looked at several things in order to keep. Very important for us is fundraising is more important than fundraising. We want to work with several organizations, both in the country and outside the country, that will help us make the life of our own patients better. And so we need to do several things in order to promote equity in the country. But I think all of it should be like what Francis P. Buddy said, no, the secret of care of the patient lies in caring for the patient. Equity, diversity, where a patient is born, where a individual lives cannot dictate whether he or she lives or dies from cancer. And inequities are systemic, but they are solvable. We need multi-sector stakeholder collaboration. The true measure, Mahatma Gandhi said, I never met Mahatma Gandhi. The true measure of any society can be found in how it treats its most valuable members. But my own professor, Dr. Krishnamurthy, whom I met and worked with, benefits of science must reach the last man in the row. If that fails, that science is of little value. I think this is something all of you will know. This is Lennon. I borrowed this also from Pramesh. All of us are familiar with this song, and I think if we all work together, we could all be one, be a globe without barriers. Thank you very much.